So at least everybody is smiling and laughing. A couple of things that I want to tell you before I begin. First of all, I am sure there was a tremendous amount of confusion in the minds of those sitting out there because Dr. Chopra stood up and said all this, and Dr. Prager stood up and said all that, and we're going like, what am I supposed to believe? And the answer is you believe me. No, seriously, what works is what works for you. And really, we're here to educate you, and hopefully you will look at this from a perspective of saying, yeah, that makes sense to me, that feels good to me, that seems right, and you'll take the other things, the things that don't seem right, or the things that we seem to be more negative on, and you'll look away from them. So that hopefully will help with some of the confusion. The other thing is, if there's anybody in the audience who wants the PowerPoint, so that you don't have to sit there and take pictures of the screen, send me an email. It's real simple. I still actually have an AOL account, which makes me old, but I have an AOL account. So Roxanne will give you the AOL account. It's actually my name. It's Getson at AOL. Send me an email. Tell me that you want the PowerPoint, and I'll send it to you. Okay. That being said, I am a medical doctor in general practice. I am a medical thermographer, and I am a Sherlockian scholar. I know, what does that mean? Well, it means that I live and breathe Sherlock Holmes. And hopefully some of you sitting in the audience will appreciate the Sherlock Holmes that I'm going to intermingle in what I'm talking about today, because for me, Sherlock Holmes was a way to be a better doctor. The reason being, when you read Sherlock Holmes, you have all of the information that you need right in front of you. You just have to see it. Unlike Agatha Christie, who decided she was going to try and fool everybody at the back end, Arthur Conan Doyle gave you the pieces to put together to solve the puzzle. And so for the last 30 years, the puzzle that was CRPS, for me, has started to fall into place little by little. I am by no means where I want to be in the knowledge of this. But when people come into my office, I sit with them for about 30 or 35 minutes before I ever get out of a chair, because I really believe that people will tell you what's wrong with them without you getting up and examining them. You can look, you can listen. You were gifted with 5 senses. You need to use them. So I'm going to talk to you a little bit today, different than Drs. Prager and Chopra did, because it's going to be a lot less technical, and it's going to be a lot different because they're concentrating on, and by no means is this a criticism, they're concentrating on the disease, and I'm going to concentrate on those things that you may have or you may know people who have that are part of the disease, but nobody seems to recognize that they're part of the disease. I want to start by this story because I think this is just, it really says it all. Holmes and Watson are on a camping trip. In the middle of the night, Holmes wakes up and gives Dr. Watson a nudge. Watson, he says, look up at the sky and tell me what you see. I see millions of stars, Holmes, says Watson. And what do you conclude from that? Watson thinks for a moment and he says, well, astronomically, it tells me there are millions of galaxies and potentially billions of planets. Astrologically, I observe that Saturn is in Leo. Horologically, I deduced that the time is approximately 3:15. Meteorologically, I suspect that we will have a beautiful day tomorrow. Theologically, I see that God is all-powerful and we are small and insignificant. What does that tell you, Holmes? To which Holmes replies, Watson, you idiot, someone stole our tent. There's a point here. Okay, so the first mention of CRPS actually goes back to the 17th century when Ambrose Paré reported that King Charles suffered from pain from a contracture of his arm from bloodletting. In the Civil War, it became causalgia. In 1900, Sudeck called it Sudeck's atrophy. In 1946, we called it reflex sympathetic dystrophy. And since then, in an endeavor to confuse the public, we've called it all of these things and more. In about 1999 or 2000, what I call the Committee on Nomenclature Committee, who I think sits around and has nothing better to do, came up with the term complex regional pain syndrome. One of my patients said complex is actually the right word because the disease is complex, and so I can't really argue with that point. But I may occasionally lapse into the term reflex sympathetic dystrophy because I've been doing this for a long time when we used to call it reflex sympathetic dystrophy, so if I do, please excuse me. It is a neuropathic inflammatory pain disorder characterized by severe pain that extends beyond the injured area and, to me, the most important thing, disproportionate to the inciting event. How my colleagues say, can somebody have complex regional pain syndrome? All they did was stick a needle in their finger. Well, I've seen people with needles stuck in their finger who wind up in wheelchairs. So it has to be understood that the injury itself doesn't necessarily have to be of severe magnitude for it to be a disease, an incident that causes complex regional pain syndrome. You have autonomic dysregulation, you have movement disorders, you have atrophy and dystrophy, but you don't have to have those. So I have individuals who say, well, this person doesn't have any edema, they can't have CRPS. Why? You don't have to have all of them. And so this is the list from the RSD website, and I'm preaching to the choir in a lot of cases here, but the term burning, which I've underlined, to me is the buzzword. That term appears in more people than any other term, and I get all kinds of words, I get all kinds of descriptive adjectives, but the word burning is paramount. And it goes on to say any type of injury that can be a sprain, a fracture, a minor, whatever it happens to be. And you can have all of the symptoms that I said, swelling and hair and nail growth and temperature change and color change, et cetera, et cetera. But to me, it really is still more important. What is the history? What does it sound like? What is the patient saying to me? How do they feel? Differential diagnosis from Dr. Raja, who's at Johns Hopkins. This is just some of the things that he put on paper. I will tell you that brachial plexopathies are not exclusive of or independent of complex regional pain syndrome. I will tell you that my adversaries, the people who work for insurance companies, this would be an appropriate time for everybody to boo. The people who work for the insurance companies will tell me that since somebody has this, that, or the next thing, we have not ruled out these other things. Well, that's what they tell me, and I'm used to it. So they developed some years ago the Budapest Criteria, and for those of you who don't know how this came about, a bunch of doctors met in Budapest, Hungary, and they decided they were going to come up with a series of subjective and objective criteria which lent themselves to a diagnosis of CRPS. Now, this was both good and bad. It was good because it finally gave us some idea of where to go. And it was bad because there were people who kind of sit on the fringe of some of these criteria, which again puts a bullet in the hand of the insurance industry and says, well, they don't meet the Budapest criteria, therefore they don't have the disease. So as Dr. Chopra said this morning, there are exclusions and there are fringe players in this. And you have to take it for what it's worth, which is a general criteria. But the subjective portion is 3 out of 4 of sensory, vasomotor, pseudomotor, and motor and trophic. And I don't need to read all these because you can do that and you're familiar with them either by having them or sitting next to somebody who does. The idea, however, is that if you meet 3 of the 4 criteria, you then move on to the objective criteria, which is assigned, meaning that which I can, as the doctor can see, as opposed to subjective, which means that you as the patient complain about. But the last one here, the one that says there is no other diagnosis that better explains the signs and symptoms, is the one that works best for me. Because when you sit and you look at somebody, what we're doing as doctors, and I've been doing this more years than I ever thought I would, when you look at somebody as a doctor, you will apply what we call the rule out, which means in your mind you're sitting and saying, okay, I either know what this is, or my mind is rapidly working to find out what this is not. You know, a mother brings a child into my office with white bumps and the child is scratching, and they were playing with the next door neighbor child who had chicken pox, it's not real tough. But when somebody comes in with a constellation of symptoms that's been confusing to the 7 doctors that saw that person before I saw them, it becomes a little bit different. So to me, if you have eliminated things, and we'll get to a Holmes thing in a short moment, but if you've eliminated other things, what you're left with is the only diagnosis that makes any sense. So the diagnostic testing has a place, but it has a place based upon not necessarily what is wrong with somebody, but sometimes what is not. Also understand you can have concurrent disease. I mean, there's no reason you can't have high blood pressure and diabetes at the same time, and for that reason, you could have a disc herniation in your back and still have complex regional pain syndrome. I put this up because from this point on, I'm about to get opinionated, and so please take it as my opinions based upon 1,400 patients in 30 years. This is a description of the disease, and I underlined the words that were important to me, which were migrate, stabbing, shooting, non-restorative sleep, sensitive to cold, humid weather, physical and mental fatigue, excessive physical activity, anxiety and stress, and a few more, which include irritable bowel and bladder, and headaches and migraines, and restless leg syndrome, and Raynaud's, which is the discoloration of the skin, neurological symptoms, etc. And when I first read this, I thought, this is a terrific explanation of complex regional pain syndrome. Would you agree? Except it's not. This came from the National Fibromyalgia website, to which I draw the following conclusion. There is no such thing as fibromyalgia. Fibromyalgia, to me, my opinion, is a subsect of complex regional pain syndrome. So when somebody walks into my office for an evaluation, and I know they're there for a pain evaluation, and they say to me in their history, I had fibromyalgia, I know where I'm going, because they probably never had fibromyalgia, because in my world, fibromyalgia doesn't exist. And there are at least 2 references in the medical literature that agree with me, which doesn't make any difference to most people, but that's where I come from. Okay, so as both Drs. Chopra and Prager talked about, we talk about the spread of the disease, and Dr. Schwartzman, who's mentioned constantly as the guru in this disease, who, as Dr. Prager mentioned, is sitting on a dock fishing someplace in Florida, for which I hate him. He and I worked together quite a bit, and I wished him well when he retired at the age of 75, because by that time he had seen over 4,000 or 5,000 people with this disease, and had done more than anybody else to better the lot and life of so many people in the research into the disease. But he wrote in 2001 that the disease will spread, and the spread can occur up to 8 years after the disease actually occurs. It will spread in 95% of the cases, either horizontally or vertically, and in 5% of the cases diagonally. And almost invariably, the patient will say that the second place, the second limb, is worse than the first. Some exacerbating factors, stress is and belongs at being number 1. Changing barometric pressure, which sets everyone off. Humidity, poor diet, vaccinations, which we could go on. I could probably do an hour talking about the evils of vaccinations. Aluminum in toxins, certain prescription medicines, Lyme disease, which is really underdiagnosed and underthought of as a contributing factor in complex regional pain syndrome. And so Conan Doyle said, life is infinitely stranger than anything that the mind of man can create. Can you imagine anybody other than Stephen King coming up with this diagnosis of complex regional pain syndrome? So diagnostic testing, well, there's a list here. We talk about x-rays and CAT scans and MRIs, and I'll come back to bone scans in a minute, and discograms and myelograms and arthrograms and lab tests and electrodiagnostic testing or EMGs, somatosensory evoked potential testing, and quantitative sensory testing. And all but the quantitative sensory testing really does not help you with a forward diagnosis of complex regional pain syndrome. QST testing, which measures vibratory sense and temperature sense, is really not a bad test, except that you really have to go long and hard to try and find a machine, because there are very few of them anywhere in the country. Thermography, on the other hand, which was mentioned by Dr. Chopra this morning, there was one slide that Dr. Prager showed. Thermography is something that's very near and dear to my heart. I've been doing thermography for the last 36 years in this country, making me the longest tenured thermographer in America, which means that I'm old. But I've been doing this, and I've done more neuromuscular thermograms probably than anybody else. And what I have found is that thermography is the only diagnostic test to absolutely positively confirm a diagnosis of complex regional pain syndrome. Thermography is infrared imaging, and for those of you who don't know anything about infrared imaging, infrared is at the opposite end of the spectrum from ultraviolet. There is nothing emitted from an infrared camera. It absorbs. So when you stand in front of an infrared camera, what happens is that the camera perceives the body's heat and converts it into a picture that I'm going to show you in a moment. And the picture can be taken in black and white or in color, and it measures skin surface temperature. And it's a measure of the sensory abnormalities of the sympathetic nervous system. And the last time I looked, CRPS was a disease of the sensory nerve fibers of the sympathetic nervous system. So it is a wonderful diagnostic test that unfortunately received bad press by many, many people, and it's been around in this country since 1957. There are no contraindications whatsoever to thermography. All you need to do is stand in front of a camera, and if for some reason you can't stand, we figure out a way for you to sit in front of the camera. So I want to give you a case history just to illustrate. This is a 40-year-old female who was sitting on the third row of a football stadium at Lincoln Financial Field in Philadelphia, which, by the way, is the home of the Super Bowl champions. By the way, in case you didn't know, I was born and raised in Philadelphia. I live in New Jersey. Anyhow, she was sitting there at a charity event when one of the players, who happened to be the punter back at that time, kicked the football into the crowd. Now, the idea was that the players were throwing footballs, or in this case, kicking a football. It went up into the crowd, and they were supposed to throw it back, and they moved around, and they were throwing the balls and kicking the balls, and it was a charity event. Well, this particular time, the ball went way up into the stands, and the guy who caught it thought that he was a professional quarterback, and he was going to throw it from where he was all the way back onto the field, except that he didn't. And it came hurling at this poor woman's face at whatever speed of the football travels, plus the gravity factor coming on a downward arc. And she turned around to look up to where the ball was, and lo and behold, it was coming at her face. So she did what anybody would do. She put her hand in front of her face to block her face, and in doing so, she saved herself a broken nose and facial injuries, but she broke her hand. And so she had her hand put in a cast, and she had it set, and 6 weeks later, they took her hand out of the cast, and lo and behold, her hand was worse than it was before they put it in a cast. And so we took thermographic pictures, and the picture that you see on the left is her left arm, and on the right, and those circles that are drawn on there are circles that I draw, and I want to show you, if you look here, if you see this, it should be the same as this, and it's not. Everywhere that you look here, from down here in the wrist to over here down in the wrist, there's a temperature differential. And we have standards. And the standards that are applied of that of the thermographic community tell us what's acceptable and what's not acceptable in terms of symmetry or lack of symmetry. So we went ahead and we did her hands. And for those of you who's never seen a thermogram, which is probably most of you, if you're not colorblind, you see that these two hands look really different. And what's even more interesting is when you look at the left hand, which is on the right side of your picture, it looks like she doesn't have any fingers, because her hand is so cold in that picture that you actually can't even see her fingers. So the moral of this very brief story is that I now have something that there's no other diagnosis in the world that will give you this pattern. So if I'm talking to a group of people, and they tend to be 8 in a jury box sometimes, if I'm talking to a group of people, there's no way that somebody can be making this up. It can be in their head, or it can be any other disease than CRPS. An interesting addendum is I actually had some other pictures that show you this actually extended down to her legs. But the point being made here is, in a very simple way, I can prove my diagnosis without any harm. So the whole Sherlock Holmes thing, and the reason I bring it up is because it's about logical reasoning and deduction. And so Conan Doyle wrote, most people, if you describe a train of events to them, will tell you what the result will be. Well, that's fine. If I tell you this, then you know what the answer is. They can put events together in their mind and argue that this is what's going to happen. However, there are a few people who, if you told them the result, could reason backwards to come up with how it got to that point. And in essence, isn't that what we're doing? Isn't that what I'm doing when I walk into a room and someone is sitting there in that room with a thing, and I'm saying, tell me how this happened. Tell me how you twisted your ankle when you fell in that hole. Tell me about how you fell. Was the arm outstretched? Because I already know what I've got. I want to know how it got to there. So you see, as I go along, why I have incorporated for this presentation today the ideas of Sherlock Holmes and Conan Doyle. Again, I'm preaching to the choir, but I have some pictures. Okay, vasomotor changes of discoloration, hyperhidrosis or abnormal sweating, a dystonic hand, which is a motor disturbance, a dystonic face. Most of these things you at some point have seen. I've got one or two that you may not have. This is a young girl in my office in a chair receiving ketamine, and as you see, her right foot is dystonic. Now, she's sound asleep when we took this picture. She was 15 or 16 years old at the time. She was sound asleep, and she still had the dystonic foot. 5 days later, after ketamine, that's the same limb with her sound asleep. Neurogenic edema. This is not edema that will respond to diuretics, to water pills. This is edema or swelling that comes from the irritation of the nervous system. And you see the pitting of the skin that goes along with it. This erythema or redness, this is a lady that comes into my office, and if her knees look that way, she doesn't have to open her mouth because I know she's in a flare. Here's one you may not have seen. This is called Libidoreticularis, and that's what this woman's stomach and abdomen look like all the time. Her arms look the same way. Okay? And with her, when she goes into a flare, it gets very red, almost to purple, and it begins to scale, and the skin gets very dry, but she's never without that look on her stomach. Stasis Dermatitis, meaning that the blood is not flowing properly, usually accompanying edema, and the skin gets very dry. And the last one, this is a lady who is not pregnant. Now, I'm sure that if I had just put the slide up without the word gastroparesis up there, you would have thought this lady was pregnant. But you can't get pregnant without a uterus, and she doesn't have one, okay? And this is her abdomen. Just in a bit of a history, it got this way. She had a pre-existing CRPS diagnosis. She was taken to the operating room for an emergency appendectomy. It went without problem. A year later, her abdomen looked like this. She has had every diagnostic test that I could possibly think of. She has been seen by 2 gastroenterologists and 2 surgeons, and nobody has any idea why her stomach is like this. Every one of her tests is normal. So one of the surgeons took her to the operating room and opened her up laparoscopically, when I say opened her up, and said she had some adhesions from the surgery. Well, that was fine. So he cut her, lysed the adhesions, and her stomach went down by about half, and it stayed that way for about 3 months, and lo and behold, it came right back to this way. And the only thing that took their stomach down, and this amazes me, so I know it's going to amaze you, the only thing that took her stomach down, she had an abscess tooth, and the tooth was pulled, and her stomach went down flat. It didn't stay that way, unfortunately, and the only relief she gets is when we infuse her with ketamine, and it never goes back to normal, and we're still looking for ways to get it there. We see, but we don't observe. We observe, but we don't see. Which one is it? We observe, but we don't see. It's right there. It's looking at you. It's telling you what it needs to be. So let's talk a little bit about systemic manifestations. You know what it feels like to have a dystonic limb. You know what it's like to have a bad arm, a bad neck, a bad back, et cetera, et cetera. But let's talk about some of the other things that happen in this disease. And why wouldn't they? You've heard 2 doctors today say that this is a central disease. This is the disease of the nervous system. This is a disease that begins in the brain. Well, the nervous system affects all of you. Why would it just affect an arm or a leg? It doesn't make sense. It has to affect other places, and it has to affect the organs. So, okay, gastrointestinal, peptic ulcers, irritable bowel disease, nausea, vomiting, et cetera, et cetera. The main thing that I get is gastroparesis, which is sluggish movement of the food from the time that it's eaten to the time that it's eliminated, because what it's doing is it's sitting in the stomach. And it's sitting in the stomach because the pyloric sphincter, which opens on the back end of the stomach to let the food out after it has been treated by the acids in the stomach, is not working right because the nervous system is malfunctioning. So the gastroenterology people will go in with an endoscope and they will put some Botox into the pyloric sphincter. It will relax the pyloric sphincter and normalize the situation. Gastroparesis is a disease of diabetics, predominantly. But once you know that somebody's not diabetic and you see that they're sick all the time, they eat 3 mouthfuls and throw up, okay, they're constantly full. There's no other reason for it. Sometimes the gastric emptying study, which is an X-ray, helps. But when people have the gastroparesis, you've got to do something definitive. And it's easy because you can do it through a scope. And Botox injections last generally anywhere from 3 to 6 months. Sometimes if you're using concurrent therapy, like ketamine, they may last longer. So I've had 2 failures on Botox, both females, both with intractable pain, nausea, and vomiting. And the amazing thing is that the only 2 females where it didn't work were sisters, both of whom had CRPS. Both of whom wound up in the operating room, successfully, I might add. You have pancreatitis. Pancreatitis is generally, again, a disease of diabetics, a disease of alcoholics, a disease of trauma. Somebody hit you in the pancreas, you develop pancreatitis. Lots of people with pancreatitis and CRPS. with elevated enzymes. And the GI people scratch their heads, and you've got to intervene on their behalf if you're me and say, listen, I understand that you've eliminated all the usual causes. It's coming from the CRPS. Dysphagia, difficulty with digestion, irritable bowel syndrome, constipation, which is more often than not opioid-induced, biliary dyskinesia, which is gastric upset, for lack of a better word, urinary incontinence, dysuria, pain on urination, inability, difficulty to avoid, people who think they have interstitial cystitis but don't have interstitial cystitis, they have neurogenic bladders. So they go to urologists, and the urologists treat them for interstitial cystitis, and they don't get better, and they wonder why, because it was never the problem in the first place. And in order to get rid of the problem, you've got to treat the disease. You can't treat the symptom. Sometimes, as it says in this note, lumbar epidural infusions with bupivacaine in the hospital will cause the bladder to reboot itself. And it's a thought process for anybody out there who may be experiencing this firsthand. Vertigo, very common. You treat the symptom, sometimes you treat, but listen, with all this, you treat the disease, because if you treat the disease, the symptoms get better. But sometimes you treat the disease and A or more symptoms don't get better, and then you've got to treat the symptoms. Meclizine is antivert, which makes people very tired, but it does work in some cases. Syncope is blacking out, and it comes from autonomic dysregulation. The footnote is at the bottom. Syncope is not real common, but not unusual. And so I have an interesting case presentation. A 44-year-old female was involved in an accident after she'd had CRPS, which got worse from the accident. And what happened was that there was a parade going by, and somehow one of the trucks had a boat on it or something that was sticking out, and it went to hit her, and she put her arm out, and it threw her arm back and stressed her brachial plexus. And so she began having drop attacks. She would walk out of my office and fall on the ground. She would get up at home and fall on the ground. I mean, literally, she would just drop to the ground like somebody hit her with a sack of whatever, and she would fall down. So she went to neurology, and they had no idea what was wrong with her. And she had a brain MRI, and she had an EEG, and she had laboratory testing, and she had a Doppler and ultrasound, and everything was negative. And sometimes, for whatever reason, I listened to my inner self, and I said I had an idea, so I sent her back for an ultrasound, a Doppler of her carotids. And the technician said, we've already done this. And I said, yeah, but I want to do a little bit different. So we did the both sides, and she said, everything is fine. I said, well, here's what I want you to do. I want you to turn her head to the left, because her brachial plexus on the right had been irritated in the accident that I just explained to you. I said, I want you to turn her head to the left, and then call me back. And so about a minute and a half later, she called me back, and she said, she's on the floor. And I said, the problem was that when she got hurt and she injured the plexus, she did what a lot of plexus people do. She did this. And she shortened up the artery on this side. And in doing that, she crimped the blood flow. So when she turned her head this way, she didn't have enough blood coming up the side of her neck to her brain, and she felt she could turn her head this way. She had plenty of blood over here, but when she turned this way, she went down on the floor. So we put her in a cervical collar, so she couldn't do that, and she stopped falling on the floor. It is a capital mistake to theorize before you have all the evidence, because if you take the other stuff, this lady would still be walking around falling down on the floor, just as an answer. Migraines, one of those overused terms in medicine. Arthritis is another one. Migraines, for migraines to be migraines, there are a certain set of criteria, and people come in and say, I have migraines, but when you talk to them, they're generally not migraines. I see a tremendous number of greater occipital headaches, and the picture there really shows where the greater occipital nerve is. And if you inject the greater occipital nerves, and I do this, I'm not an interventionalist, I do very little injection, but I use homeopathic agents. I don't use conventional medicine when I do my occipital nerve blocks. And if I inject somebody's occipital nerves, they will be headache-free before they leave the room, is how fast it works. And it lasts months and months and months. I generally get 6 months out of an occipital block, and it comes from the disease, and it comes from that posturing where you shorten your neck because your neck hurts and you don't want to move it. Visual disturbances, double vision, blurred vision, ocular migraines where you see the little floaters and the lightning bolts and things like that. Vision loss, field cuts where you can't see to one side. Photophobia, meaning bright light bothers your eyes. Burning of the eyes is something that's happening more and more. And I guarantee you, as I go through this, there are people sitting in front of me who've experienced one or more of these things, and one of two things happens. Either you don't equate this as being part of the disease, or you're sitting in front of a doctor who tells you it can't be part of the disease, or both. This otorhinolaryngol, I love that word, laryngol, I can't say it. Anyhow, otophobia is the irritation of the ears from loud noise. When I have a husband and wife come in and I'll say to her, does loud noise bother you? And the husband goes, I'm sick and tired of turning the television down. I can't hear anything that's on the TV. I'm reading closed captioning. So not unusual. Vibration. People literally driving in a car and the kid in the next car has the bass turned all the way up and they feel that vibration in their inner ears and it sets off their pain. Hoarseness. They get up in the morning and you can't talk and it lasts a half hour and you're not sick and it goes away. It's from the irritation of the branchial plexus, not the brachial plexus. All part and parcel of the same thing. Dental issues. Why? I have 22-year-olds in my practice with no teeth. They've either fallen out or they've been extracted. Sometimes because of dietary indiscretion, sometimes because of immune compromise, sometimes because the nervous system is damaged and the nerve roots are damaged, so the teeth are literally falling out. And the other thing is that diet and lifestyle, which I'm going to talk about at the end of this, creates a situation where you have poor oral hygiene and you get decay because sometimes it hurts to brush your teeth. Dermatologic, normally neurodermatitis. I heard Dr. Prager talk about using ketamine cream. If it works, that's fine. Sometimes topical steroids will take the itch away. These things come and go at will. Sometimes you'll have them for weeks at a time and then not have them for months at a time, but normally neurodermatitis. Anybody ever hear of Derkham's disease? Okay, well, lipoma is a fatty tumor, and you see one, this is the fatty tumor right here, okay? Derkham's disease is painful lipomas, painful fatty tumors. It's not very common. I'm not surprised that no one's heard of it. I have exactly one patient with the disease. There's actually a Derkham's disease foundation in either Colorado or Arizona, but it has to do with these eruptions of perfectly normal benign fatty tumors, usually on the abdomen, but they can appear other places, that cause a tremendous amount of pain. Mortons Neuroma, anybody here in Mortons Neuroma? Mortons Neuroma, so it's a mechanical nerve problem, generally between the second and third interspace. And the well-meaning podiatrist will go in there and operate on it, which is a pretty much guarantee that I'm going to see them in the practice. Because Mortons Neuroma surgery is really, really scary if you're predisposed to CRPS. And I can't tell you how many people I've seen that have that. Okay, it just isn't an answer. Injections aren't the answer. They're going to cause the same problem. What does work is cryosurgery, where you actually freeze the neuroma. We've had great success with cryosurgically treating neuromas. The problem with that is finding somebody who does cryosurgery to neuromas, but don't let them operate on your neuroma. Cognitive dysfunction, short-term memory loss. One of my favorite things, I can tell you exactly what I wore to my senior prom, but I can't tell you what I had for breakfast this morning. And I got all the heads going because it's exactly the way it is. It's exactly the way it is. Back to Sherlock Holmes. The little things are important because it's like building a puzzle. You're putting the pieces together. You're constructing a diagnosis. It's easy when somebody comes in with a red, swollen, sweaty, dystonic foot after they twist it. I mean, that's easy. They don't make it to me. The RSD Association says the average patient sees 4.3 doctors before they get to somebody who makes a diagnosis, and I think that's low. I used to tell the association that I was 0.3, but it's now 7 or 8 or 9, and I get stacks of charts, and you have people who go, well, it can't be that, or you have other people who go, well, maybe it's that, and I try to tell the doctors that I talk to, if you want to do the patients a favor, when you've exhausted the things that you can do, send them to somebody who can do something else. I had a medical school professor in the 70s who said to me, and I never forgot it, if you want to be good at what you do, know what you know what you don't know, and find somebody who knows what you don't know. And I've lived that way for 42 years. And I try to, when I talk to doctors, I say, look, before you start doing invasive things, before you start operating on people, before you start ruining their lives, if you're not sure, don't. I can't tell you the number of people that come into my office that had carpal tunnel surgery and never had carpal tunnel syndrome. And how do you know? Because the carpal tunnel affects 3 fingers. This one, and half of this one. And people come in, oh, it was my whole hand. Then it can't be carpal tunnel syndrome. It's just that simple. Oh, there's shortness of breath, inability to take a deep breath, neurogenic edema, which I showed you, muscle weakness and atrophy, adrenal dysfunction. My God, if there's anybody that has this disease that has a normal adrenal, I'd like to meet them with the stress that the adrenals are placed under, with the constant chronic pain. And for that matter, anybody living with somebody that has this disease that has normal adrenal function, or in my case, anybody who's treating people with this. Gardner-Diamond syndrome, spontaneous bruising in an area without trauma. Okay. I woke up this morning with a black and blue hand, and I have no idea why. Lethargy, fatigue, and sleep disturbance. How many people in this room sleep well? How many people in this room just went deaf? Okay. So another thing about genetics, a 37-year-old female casino worker is struck by a money cart. Back in the days, they used to actually have money in casinos as opposed to paper, and there was a ramp like this one, and the guy who was pushing the cart lost the control of it, and it ran down here, and it ran into one of my patients, and it hit her in the thigh, and she subsequently developed CRPS in that leg, and it migrated up into her arm. And a year later, her sister, who was a police officer at the age of 35, was broadsided in a patrol car, and the handle of the door went into her left thigh, and she developed CRPS, which migrated into her left arm. Now, you might say that's coincidence, except I have 19 families in my practice where the coincidence is the same disease in multiple members of the same family. At 19, it's not coincidence, it's genetics. Now, if I had a quick $1 million, I could do a genetic study, because that's what they told me it would take to do the genetic study to determine what that gene is. But make no mistake about it, there is some kind of gene that we have that predisposes people to this disease. In most cases, it requires trauma to set it off. And for those of you who are adults and have children, that's scary. But it also is enlightening in the sense that if you're sitting there suffering from this disease and you have children, you're going to be particularly attentive to any injury that he or she sustains, and you're not going to let it get out of hand. Now, I'm not standing here trying to scare you. I'm trying to give you facts, and I'm trying to let you know that this is what I found. So it's just pretty much pay attention. Medications, there's a list. A couple of these you may not be familiar with, and one I want to talk to you about. On the right side, Neurodermatitis is the study that I believe Dr. Chopra was talking about this morning. Let me enlighten you on what happened with that study. There were 11 women in that study. They were all women with CRPS type 1, all diagnosed within 6 weeks of the time they started the Neurodermatitis, and all of them got better. And we sit around and wonder why this study was skewed. Because how often do you see someone that you make a diagnosis and initiate treatment within 6 weeks of the inciting trauma? So they are doing a study right now with Neurodermatitis across the world. They spent a great deal of money doing it to determine if, in fact, the drug will work or not. I have a half a dozen patients that have had the drug. I haven't been real impressed with it, but that's just my 6 people, and it's not enough to make a decision. But that's what Neurodermatitis is. Lenalidomide, for those of you who are old enough to remember thalidomide, that's what that is, and they're back to using lenalidomide to some degree in non-childbearing age women because of the horrors of birth defects that came with thalidomide. Mexiletine is oral lidocaine. Amantadine is an interesting drug. It's a drug for influenza that has absolutely no side effects whatsoever, and in some people it actually helps the CRPS. It's a prescription drug. It has no side effects at all. The one thing I do want to talk to you about is antidepressants. This is a pet peeve of mine, so please take it for that. How many people in the room at this point in time are taking Cymbalta? Not too bad, about a half a dozen. It's a horrible drug. Okay, get on the internet if you're taking Cymbalta and type in the word Cymbalta lawsuit. And seriously, look at the class action suit that's going on against the Lilly company for what they didn't tell you about Cymbalta. Okay, and I'll leave it at that. But here's my point. We put people on antidepressants because they're depressed. And I have what I call the Getson questionnaire of depression. It's a one-question questionnaire. Here's the question I ask somebody. Fill in the blank. I'm depressed because. Now, you can shout it out if you want, but my guess is is there anybody in this room that can't fill in that blank? Okay. There's two types of depression in this world. There's what we call, the words are escaping me at the moment, but there is depression that comes from within and depression that does not. When you know what the depression is coming from, it doesn't make sense to take antidepressants because you are not going to be less depressed until you get rid of what the depression is coming from. If I take my hand and I put it on somebody's chest to the point that they are in screaming agony pain, I can give them a shot of Demerol and the pain will go away. Or I can just move my hand. And we're putting people on antidepressants, which is making the body say, well, I guess I don't need to make serotonin anymore. I guess I don't need to make dopamine anymore. I guess I can take the rest of my life off and not do what the body was intended to do. It's not going to work. Get rid of the problem, and people won't be depressed anymore. Now, if there was someone in here who couldn't fill in the blanks, that's a different story. Because now you have a biochemical problem that has to be dealt with. It's not a situation. You're depressed because you're in pain. You're depressed because you have no life. You're depressed because you take medication. You're depressed because somebody died. Whatever it is, fix the problem, or at least deal with the problem. I told you it was a pet peeve of mine. Opioid-induced hyperalgesia is mentioned because we're having an opioid crisis. We're giving all these medications to the poor people who don't need it and not giving it to the people who do. And I'm not going to get started on that because it'll get me in trouble. But that being said, please understand that there is something called opioid-induced hyperalgesia, which means that you can make your pain worse with opioids than it was without opioids. Okay? You've been inundated today with ketamine. I'm not going to do that. I'm going to tell you two things. Number one, just to slightly amend what Dr. Prager said. Ketamine came to this country in 1999. A doctor by the name of Ron Harbit was in Australia when he stumbled onto it with another doctor by the name of Graham Carell. And they came back to this country, Harbit did, with the idea of using ketamine on an inpatient basis. And Ron Harbit is a nice man and a very bright man, but he didn't know what to do with this piece of information that he found. So he came east where he met with Bob Schwartzman and myself back in those days, and we talked about what we were going to do with the ketamine. And Dr. Schwartzman, who was then chief of neurology at Drexel University College of Medicine in Philadelphia, and I on the other side of the bridge, began using ketamine in a hospital-based practice about 13 years ago. 11 years ago, I started using it as an office-based drug, which makes me have somebody who's used it longer than anybody else. The protocols that were put in place years ago were put in place by Dr. Schwartzman and myself. They have since been changed by any number of doctors throughout this country. I am not going to stand here and tell you what's right or what's wrong. I'm going to tell you that the protocols that we put in place were for lower dose ketamine, and I'm going to leave it at that. I will tell you that 2 Octobers ago, a group of doctors met in Chicago about the time the Cubs were winning the World Series, so it was a crazy place to be. And we sat down and we decided we were going to write some protocols for the administration of ketamine. And the only thing we were consistent on was we agreed to disagree because people were all over the place. There were people here and people there, and we all just shook our heads at one another. But there are protocols that were written that are out there in the medical literature and available for review. What I am going to talk to you about is a paper that Dr. Schwartzman and I wrote together about ketamine in surgery. Because what this stemmed from a trial of patients in his office and in mine. And what we did was we took patients who were going to surgery, and the surgery was anything from the extraction of wisdom teeth down to foot surgery, and we gave them intraoperative ketamine. We made it a mandate. Basically, I said to the patient, if they're not going to give you ketamine, get up and leave. And so they all had it, and it was a small study. My portion of the study was 20 people. His was just a few more. And out of 20 people that had various types of surgery, the number of people who extended the RSD as a result of the surgery was 0. And since that paper, which was written, I want to say 6 or 7 years ago, the number of my patients who have extended their disease with intraoperative ketamine is 0. So I get on the phone. I call the surgeon or the anesthesiologist, and I say, this is the way it's going to be. Now, make no mistake about it, you cannot tell an anesthesiologist how to give anesthesia. I can't do it. Forget about you being able to do it. They are not going to listen. So I put it in writing, and I found the trick. And it says, this patient must, M-U-S-T, big letters, have ketamine during surgery. Because when you do that, if they don't give them ketamine, they're committing medical malpractice. I found that out because an anesthesiologist told me that. I thought, this is cool. So I get on the phone and say, look, I don't care what you give them, as long as the ketamine's in the bag. And they will generally say how much, and that number, based upon weight, goes anywhere from about 90 to 125 milligrams. It doesn't need to be a lot. But for me, at least, standing here in front of you on this date, it's been wildly successful in preventing the spread of the disease. I'm not making people better, I'm just preventing them from getting worse. So the one ketamine fact that I want you to leave with today, other than the fact that I think it's terrific for people with refractory pain, and that I don't believe you should not do other things, is if you're going to the operating room, I don't care if you're going to a dentist's office and having a wisdom tooth pulled, get the ketamine. So, you know, you've heard about spinal cord stimulators and this and that. I'm not going to repeat the things that you heard. I want to spend a little bit of time talking to you about what the world calls alternative treatments, because you need to understand something. Ketamine never was intended to be the be-all, end-all of the treatment of CRPS. And anybody who tells you different is wrong. It was intended to be something to get people into the arena. And I tell people, I'm a great one for analogies, and here's one. I say, if you're out in the Wild West and there's a white stallion out in the prairies, and you want that horse, you got no shot at that horse until you bring that horse into your corral, into your world, into your field of vision, because out there he's on his own and you can't do a thing with it. And when somebody comes into my office who's out there, okay, the ketamine will bring them in here. If I get more than that, that's a blessing. But if I get that much, I've done something good. So we talk about diet and lifestyle alteration, gluten-free foods, I'm going to talk about in a minute, organic and healthy foods, smoking and alcohol cessation, home exercise, Reiki, I'll come back to that in a second, manipulation if you can, acupuncture if you can tolerate it, vitamins, and I'm going to talk about all these things for a minute. But I want to talk to you about Reiki for a minute. My wife is a Reiki master, and if you don't know what Reiki is, it's energy medicine. It is the healing through energy fields. It goes back thousands and thousands of years into China. It is non-touch. Nobody's putting their hands on you. They're working in your energy field. We did an unbelievable study that I didn't bring with me today, but I'll describe it to you. We took a woman with CRPS in 3 limbs, mostly in her right upper extremity, and we took a set of thermographic images. And when we took the thermographic images, there was a marked lack of symmetry between the 2 hands. And then she went for 60 minutes and she had a Reiki session, and we took another thermogram, and they were closer together. And at the end of 6 weeks, the pre-Reiki pictures were completely symmetrical. In the previous 5, they were getting more and more of that. But by the 6th week, her 2 arms were exactly the same, and we had changed nothing else. We had changed no medicine, no diet, nothing. We kept everything constant except the once-a-week Reiki sessions. And for those of you who love the picture's worth 1,000 words, you look at these pictures, they're riveting. So if you're looking for something, you got to think outside the box. It's a place where I live. You can't think with blinders on. You can't do that. There's too much out there that's untapped. 7 foods to avoid: NutraSweet or any artificial sweetener. MSG. Walk into a Chinese restaurant. First question: do you use MSG in your food? Yes. Bye. See ya. I'm out of here. Sugar, fructose, simple carbohydrates, caffeine, gluten, and nightshades. Not one that people recognize very much, but the elimination of potatoes and tomatoes and eggplant and nightshades makes a big difference in pain. Again, gluten, processed food, stress. I put this in there. I always wondered how, I put this in there and go, I want you to eliminate stress in your diet, folks. And everybody's sitting there going, okay, how? Let's talk about gluten. Gluten is actually an autoimmune disease, gluten sensitivity, and it creates all kinds of problems. It affects the brain, the heart, the joints, the digestive tract, and it is responsible for so many disease states. And it didn't used to be that way, but it is now, and that's what we're stuck with. I will tell you that if you eliminate gluten from your diet, and you do it as if it were a religion, you will feel better in a week. I am not saying you're going to feel all better. I don't want to be you told me I feel better, I'm still hurting. You will feel better in a week. And if you don't believe it, try it, and then try going back and having a pizza and seeing how you feel afterward. So they came up with a list in the New England Journal of Medicine of 55 diseases that can be caused by eating gluten. And that word is down the bottom in red there. But if that word is down there, then you all know, because you've been listening intently for the last half hour or 40 minutes, that that means that CRPS is part of this list. They probably just had no idea, the person who wrote this article, what CRPS even was. Neurotransmitters are chemical messengers. You know, we talked about the things earlier today. I'm trying to keep it as straightforward and simple, but neurotransmitters are the communication entities of the brain. They are things that cause, they're dopamines and serotonins and things like this. If you want to take something because you're depressed, and I'm going to bring that back to you now, then find out what you are deficient in. Have neurotransmitter testing. It's simple enough. It's blood tests. There's labs all over the country that do it. And if you're serotonin deficient, supplement serotonin. It's pretty straightforward. What's the problem? Well, you got to do a little research and find the lab. A lot of insurances don't pay for it. But really, I mean, at what price is doing the testing and putting the right key in the right lock? Hormones, we talked about adrenal before. That's cortisol and DHEA. Female and male hormones that you see, melatonin, which is to help sleep, is actually a hormone. If you're going to measure cortisol levels to address the adrenal, remember that the cortisol varies from time of day. So you want to find a way to do the cortisol levels at specific times, first thing in the morning. It's actually breakfast, lunch, dinner, and bedtime is the right way to do it. And when you find that lab that measures neurotransmitters, that same lab will measure adrenal function. B vitamins, pretty simple stuff. Be careful of B6 in your dietary regimen. Excess B6 can cause an increase in pain. If you're not taking vitamins, remember that vitamins come from your food. But if you're not eating properly for whatever reason, then supplement yourself with a vitamin. And B vitamins are important. If you're going to buy B vitamins, please don't go down to the corner drugstore and buy them. Find a reputable place, and not the vitamin shop. Find a place that really deals with vitamins and understands vitamins. Or go to a holistic practitioner who deals with one of the many nutraceutical companies in this country and get a real good quality vitamin. It's going to cost $5 or $6 more. It's well worth the money that's spent. Supplementation, every one of my patients sees this list. Fish oil. Again, I could go on and on. Not only does fish oil reduce triglycerides and improve heart function, it's great for the healing process. Probiotics every day. Multivitamins. I just talked about vitamins. Vitamin D3, you get your vitamin D3 from the sun. Now, I'm in California, okay? I live in New Jersey. It's a little different, okay? Go out in the sun for 20 minutes a day without a sunscreen on. Go out in the haze of Los Angeles for 20 minutes a day without a sunscreen on. You're still getting the sun. But no more than 20 minutes because of the skin sensitivity that comes along with this disease. I don't want you to burn, but you get enough vitamin D from 20 minutes a day to be therapeutic. Magnesium for cramps in the legs. I have no proprietary interest in this, but there's a product called CALM, C-A-L-M, which has calcium and magnesium in it. You can get it at Whole Foods. You can get it online from Amazon. Okay, it comes in powder form and tablet form. It has calcium and magnesium in it. Take a dose before you go to bed at night. It's tremendous for leg cramps. It's a wonderful, wonderful product. Digestive enzymes. How many people in here are on one of these drugs, like Prilosec, Axid, Pepcid, Nexium, because your stomach doesn't work right? Okay? So what they're doing is they're reducing the acid in your stomach. Backwards. We don't have enough acid. We need the right kind of acid. So what you want to do is you want to get digestive enzymes. You want to digest the food a little bit better. There is a product, again, I have no interest in this, I tell you right now. There's a company called Standard Process. It's the largest nutraceutical company in the world. Standard Process makes a drug, wrong word, makes a product called Zypan, Z-Y-P-A-N. It's retail $19 a month. So we're not talking about, it's a marvelous digestive enzyme that you can take right with your meals, and it solves so many problems for so little money. Zypan, Z-Y-P-A-N from Standard Process. You can go right on to standardprocess.com and order it. And again, I mean, I'm just talking from experience. 5-HTP, acts as a painkiller and antidepressant. DLPA has opiate agonist qualities. Methionine, fish oil, which we talked about before. Fish oil is like ibuprofen in reducing inflammation. B6, zinc and magnesium for pain relief. Want some things to read? Here's just some things that we offer up. The Diet and Mood Cure by Julia Ross. Sugar Blues, about the evils of sugar. Anti-Inflammatory Zone by Barry Sears, Clean Gut by Alejandro Younger, Hungry for Health. Hungry for Health is part of a whole series of pamphlets and books written by Sue Silverstein, who is a friend of ours in Pennsylvania, who has an association called Center for Cancer Education, but talks about the benefits of eating properly in disease. Most of what she talks about is cancer, but in disease generally. Misdiagnosed about the adrenal fatigue link. Wheat Belly is a book that I recommend to my patients, which is all about gluten and why you should never eat gluten. And the last one, Weston Price, who is long deceased, was a dentist who traveled the world looking at primitive cultures and how they advanced and how they ate. And he brought this back and talked about how people thrived on primitive diets and how they're going down the drain from the other. My favorite Sherlock Holmes. Okay, and I started to allude to it earlier. My favorite Sherlock Holmes says, when you've eliminated the impossible, whatever remains, however improbable, must be the truth. I rarely give a presentation that doesn't appear someplace, because it's true. Now, you heard me say earlier in the presentation, no other disease process best fits the description. It's not really very different from this. Okay, because that's what we do. Doctors won't admit it, but that's what we do. We sit there and we say, okay, I'm not really sure what's wrong with this person sitting in front of me. I need to figure this out. And really, if we apply logic and reasoning and we listen and we look at all the facts and all the little witticisms that I put in here today, you not only become a better doctor, but you become a much better diagnostician. And you become good at what you do, because now you're actually listening to people who are not only talking to you, but they're showing you. You walk in a room and somebody's sitting like this, that tells you something. I mean, dystonia is one thing, but the little subtle things. If you go to shake somebody's hand and they give you the opposite hand, it's telling you something. It's the little things that matter the most that, unfortunately, American medicine in the 21st century has eliminated. And it's eliminated it because to do that takes time. And most people don't take time because time is money, and we go on. And that's, I mean, I go off in all these different offshoots of things. So I want to leave you with one thing that is not in here. A lot of this is about perception and attitude. Right? And a patient walks into my office and they say, my RSD flared up today. And the first thing I said is, it's not yours. Don't own it. You don't want it. Give it to somebody you hate. All right? It's okay to say, my pain is worse, okay? But once you start owning something, it becomes a part of you. Why, as a general rule, do young people that get this disease do better than older people? Because they're more committed to going to the mall and hanging out with their friends, because they have less on their minds, because they don't look at the negative side of the things. They are focused on getting better. They are focused on being better. They are focused on being normal. And as we get older, and I'm speaking now from age and experience, our mind gets cluttered with terrible thoughts. Our mind gets cluttered with the what-ifs, and our mind looks at things and looks at the negative and forgets the positive. You need to change the thought process. You need to get up tomorrow morning and do what they did in the movie Network, where he threw open the window and he said, I'm mad as hell and I'm not going to take it anymore. Because until you do that, you're stuck. Okay, I don't care how much you mobilize, I don't care how much ketamine you get, I don't care how many doctors you see, I don't care what you do. If you don't start getting out of your own way, if you don't start looking at the positives in life, you will never get better. And have a bucket list. Have a list. My bucket list was one thing, okay? I'm going to share that with you as the last thing I'm saying. My bucket list was one thing. Anybody want to guess what it was? It's pretty straight. I've given you all the clues. I wanted to get to the Sherlock Holmes house in London. I'd never been there. So in July, I made it. And you know what? It was every bit as amazing life experience for me as I could possibly imagine. I tell people I was in London. I have 3 pictures of Buckingham Palace, 2 pictures of the guards, and 500 pictures of the Sherlock Holmes Museum. Okay, it was a life-changing experience for me, but I was going to get there, okay, at some point in my life. And so I managed to do that. Have a dream, because once you stop having dreams, you might as well pull the grass over top of your head. Have a dream and work for that dream. Work hard at it, because everybody can get better. There's always things you can do. It starts here, folks. I thank all of you for coming. I applaud you for putting up with us for all these hours of the day. It's a long day for anybody. You've been sitting for 5 hours. Thank you for listening to me. I will go outside in deference to the others and answer any questions.